On behalf of CME Outfitters, I would like to welcome and thank you for joining us today for the third in the series of 3 CMEO snacks titled Forecasting a Bright and Clear Tomorrow for Psoriasis Treatment. The CMEO snack series is supported by an educational grant from Bristol Myers Squibb Company. I'm Dr. April Armstrong, Professor of Dermatology and Associate Dean for Clinical Research at the University of Southern California. I also direct the psoriasis program in the Department of Dermatology. Joining me today is Dr. Melinda Gooderham. Dr. Gooderham is the Medical Director at Skin Center for Dermatology and an Assistant Professor of Medicine at Queen's University. She's also Consultant Physician at Peterborough Regional Health Center in Ontario, Canada. Welcome, Melinda.
Thanks, April.
In addition to CME CE credit, today's activity is eligible for ABIM MOC points. Once you complete the activity, provide your ABIM ID and birth date when completing the evaluation. CME Outfitters will submit your MOC points. You can also claim this activity as a CME for MIPS improvement activity. In this 3-part series, we're excited to focus our presentation today on some of the new data presented recently at the AAD VMX. Our learning objective for this CMEO snack is to evaluate the efficacy and safety for new emerging therapies in the treatment of moderate to severe plaque psoriasis. Melinda, we know that patients with more severe disease are faced with moving to the next step of systemic therapy. What are some of the goals and concerns patients have related to their therapy?
That's a great question, because I think when we're in clinic, patients just want to be better. We know that they want to have clear skin, but if we focus in more on what are their specific goals with the treatment that we're choosing, there was actually a survey done with the National Psoriasis Foundation asking patients what the top goals were, and patients wanted to have confidence in their therapy. They wanted to regain control of their disease that was sort of taking over, and they don't want to have that fear that the disease is going to get worse again. They don't want to live with that anxiety that they're going to lose control of the disease. They also wanted to get their skin better quickly, and they wanted to be free from itching. And that's something that we don't always think about as clinicians, that patients really are suffering with the itch. So I know this year at the AAD, there were some new therapies that were being presented. So, and I know you were presenting the late breaker for the TYK2 inhibitor, deucravacitinib. Can you share your insights of that data?
So for a very long time, I feel like for oral therapies, we had to oftentimes trade between efficacy and safety. And I do think that deucravacitinib is different. Deucravacitinib is unique in that it's a highly targeted molecule for TYK2, and it does this by really binding to the regulatory domain of TYK2 and thereby causing a conformational change in the protein. And this results in specific inhibition of TYK2. And as a result, this leads to also inhibition of type 1 interferons, as well as IL-23 mediated pathways. And as you will see, as our understanding of psoriasis has evolved, this mechanism of action of targeting TYK2 gives us an oral option that can be both efficacious and have a good safety profile. So let's take a look at 2 phase 3 studies with deucravacitinib, POETIC PSO1 and POETIC PSO2 studies. And these studies compare the efficacy and safety of deucravacitinib versus placebo and apremilast in patients with moderate to severe plaque psoriasis. And patients with moderate to severe plaque psoriasis were randomized 2:1 to deucravacitinib 6 milligrams once daily, placebo or apremilast 30 milligrams twice daily. And in these 2 studies, the co-primary endpoints were PASI 75 and SPGA 0 or 1, or clear or almost clear responses versus placebo at week 16. So what did the study results show? And here we see the results for PASI 75 at week 16 and week 24. And on the left-hand panels for week 16 results, we see that deucravacitinib, which is in dark blue, demonstrated superiority versus placebo, which is in gray, at week 16 for PASI 75. And specifically at week 16, in PSO1, about 59% of the patients on deucravacitinib achieved PASI 75 compared to 12.7% in the placebo group and 35% in the apremilast group. And the results were similar in PSO2. And on the right-hand panels, we see that deucravacitinib responses increased beyond week 16 and were also superior to apremilast, which is in purple, at week 24 for PASI 75. Now let's look at another endpoint. And importantly, among patients who achieved PASI 75 responses at week 24 with deucravacitinib, how do they do long-term with regards to deucravacitinib beyond that? And what the study showed is that with continual treatment with deucravacitinib, this resulted in the maintenance of PASI 75 response through week 52, over 80% of the patients maintaining PASI 75 through week 52. Here we look at the proportion of patients achieving DLQI 0 or 1, which is achieving nearly no negative impact on quality of life as a result of the therapy. As you can see from the left two panels, at week 16, 41% of patients on deucravacitinib achieved DLQI 0 or 1 compared to 11% on placebo and 29% on apremilast. On the right-hand side of the panel at week 24, we see that about 48% of the patients on deucravacitinib achieved DLQI 0 or 1, which is superior to apremilast results at 24% at week 24. So as we can see from this data, deucravacitinib has a positive impact on patients' quality of life. Now let's also take a look at the integrated safety data for these two studies up to week 16. And what we learned is that the total number of AEs and SAEs were similar across the groups. And adverse events leading to discontinuation were numerically lower with deucravacitinib versus placebo and apremilast. Importantly, nasopharyngitis and upper respiratory tract infections were the most common AEs in the deucravacitinib group, and diarrhea, headache, and nausea were the most common AEs in the apremilast group. Very importantly, no clinically meaningful changes were observed in total cholesterol, creatinine, phosphokinase, neutrophils, or platelets with deucravacitinib over 16 weeks. And similar results were also obtained over 52 weeks for these additional laboratory parameters. Now, these are important because when we think about TYK2 inhibition, it's important to see if there were perturbations in the laboratory parameters, and we did not see this with regards to the deucravacitinib studies, the phase 3 studies. Melinda, another agent that has performed well in clinical trials is bimekizumab. You were involved with these trials. What were some of the findings?
Yeah, so bimekizumab is an IL-17 antagonist that targets interleukin 17A and F. And we've actually been seeing some great high efficacy results coming out, especially when compared with some of our traditional biologic agents. So the Be Sure study, which looked at bimekizumab versus adalimumab in psoriasis, we saw some other analyses presented at the AAD this year looking at improvement in quality of life with DLQI 0/1. And so when the studies were done, there were basically two arms of bimekizumab. There was the Q4 week dosing, and then there was another group that after the first initial period, patients were switched to Q8 week dosing. So if we look at the Q4 week group and then the Q4 to Q8 week group, we see very similar results, first of all. And looking at those targets, such as no impact on quality of life, meaning a DLQI score of 0 or 1, we had about 72% of patients in the bimekizumab group with no impact on quality of life, compared to about 52% in the adalimumab group. The other things that patients wanted was clear skin. And again, 71% of patients on bimekizumab in either regimen were getting clear skin, compared to only about a third of patients with adalimumab. Also, body surface area, less than 1% was significantly greater compared to the adalimumab group. So adalimumab has been a great drug for many of our patients, but we're seeing higher levels of efficacy with bimekizumab compared to adalimumab. Also presented at the AAD this year was the B-Radiant study, and that was bimekizumab versus secukinumab, the first sort of head-to-head trial of interleukin-17 inhibitors. So we have bimekizumab targeting interleukin-17 AF compared to the interleukin-17A inhibitor secukinumab. And again, we see superiority with bimekizumab. So again, there was the group that was the Q4 week dosing, and then another group which switched from Q4 to Q8 week dosing for the maintenance period. And we saw 62% versus 49% clear skin, so PASI 100, 62% of bimekizumab versus 49% secukinumab at week 16. And then if you carried that out, that was 67% for bimekizumab versus 46% for secukinumab. And carried out through the whole 48-week period, 2/3 to 3/4 of patients on bimekizumab were able to achieve clear skin and maintain that over the 48-week period versus 48% of secukinumab. So here we are looking at IL-17, targeting that effector cytokine being a very effective way to treat our patients. And we're seeing a newer agent with even higher efficacy than we've seen before. So that's pretty remarkable. If we look at the adverse event profile, we see very similar rates of AEs, SAEs, and also similar rates of upper respiratory tract infection, which was the most common AE with both drugs. However, the main differentiator were the rates of oral candidiasis. So we've been seeing that consistently with bimekizumab. And in the B-Radiant study, rates of oral candidiasis were up to 19% in the bimekizumab group, compared with 3% in the secukinumab group. So we still don't know, is that because bimekizumab is just that much more effective, that you're more efficient blocking interleukin-17, that you have this side effect of oral candidiasis, or is it the added blockade of interleukin-17F? So that's something still sorting out. But oral candidiasis is an AE that, as dermatologists, we can easily manage. So we're seeing that higher efficacy with this one sort of oral candidiasis signal in the bimekizumab group.
Thank you, Melinda, for that excellent summary of the bimekizumab data against adalimumab and secukinumab. I thought that was very informative. So now for our audience, let's summarize with our SMART goals, which are specific, measurable, attainable, relevant, and timely. And we hope that you will take away from today's presentation the following SMART goals. Number one is to continue to engage our patients in discussions about their goals for treatment for their psoriasis, and to be also more aware and cognizant of the new data with regards to the development of new therapies for psoriasis. And those include TYK2 inhibition as well as monoclonal antibodies against IL-17. And I do think that these agents offer improvements in skin clearance and quality of life for our psoriasis patients, and really can add to our box of tools that we can use for our patients with psoriasis. If you haven't already watched parts 1 and 2 of the CME Snack series, they are available, and you can visit Dermatology Education Hub at www.cmeoutfitters.com. And don't forget to complete the evaluation and collect your credit for today's program. You'll be able to print your certificate from the platform. I want to thank Melinda for her insights today, and to the audience for joining me today. It is an exciting time in psoriasis drug development, and the promise of new and effective medications for our patients will certainly help them meet their goals of therapy and achieve clear skin. Thank you.